You're listening to a podcast of the World Stroke Academy, the educational platform of the World Stroke Organization. Future Stroke Leaders is an initiative of the WSO to develop the technical and research skills of the next generation of stroke professionals. The World Stroke Academy welcomed the contribution of the Future Stroke Leaders members by inviting them to cover specific stroke-related topics in our Pearls Podcast initiative.
Hi, my name is Dr. Urvashy Gopaul. I am a postdoctoral fellow at the Toronto Rehabilitation Institute in Canada. I am also a member of the World Stroke Organization Future Leaders Program. This podcast is an initiative of the World Stroke Academy, and it was felt that the importance of standardized assessments in post-stroke rehabilitation be highlighted. In this podcast, I will be discussing the importance of outcome assessments in research and clinical settings for post-stroke rehabilitation. I will provide an overview of the different standardized assessments used in stroke rehabilitation and will discuss factors to consider when choosing a standardized assessment in post-stroke rehabilitation. You may wonder why we need to assess post-stroke patients. Well, by assessing the effects of an intervention in a research trial or a clinical setting, this will allow us to better understand how patients respond to the treatment and the underlying neurophysiological changes that occur when patients improve. This allows clinicians to adapt treatment to better target stroke-related deficits for improved outcomes. Outcome measures can also help us predict the patients who might benefit most from a particular treatment. Next, we should discuss the range of outcome assessments to evaluate the impact of stroke. The International Classification of Function, Disability and Health categorizes rehabilitation assessments into 3 domains: body structure and function, activity, and participation. Body structures refer to the anatomical parts of the body, such as organs, limbs, and their components. Body function refers to the physiological functions of body systems. Impairments refer to problems in body function and structure, such as significant deviation or loss, for example, a loss of strength after stroke. Activity pertains to the execution of a task or action by an individual, such as driving. Participation refers to involvement in a life situation, such as recreation and leisure. These domains include clinical assessments of motor, sensory, cognition, balance, to name a few. Some examples of standardized clinical measures used in stroke rehabilitation to assess body structure and impairments are the Fugl-Meyer, which assesses both sensory and motor impairment in the upper and lower limbs. The modified Ashworth scale is another example of an assessment of impairment that evaluates spasticity. The Wolf Motor Function Test and the Berg's Balance Test are examples of standardized measures in the activity domain. There are other self-reported measures such as the Stroke Impact Scale that evaluates disability and health-related quality of life after stroke, that is, the participation domain. Next, let's discuss what you should consider when choosing which outcome assessments to administer. It is generally agreed that measurement protocols should be rigorous, reliable, and valid. Validity refers to the degree to which a measure assesses what it is intended to measure, while reliability refers to the consistency of a measure. Even though there are several clinical measures that are standardized, valid, and reliable, they often lack sensitivity to detect changes after an intervention. Sensitivity is an indicator of the ability of an outcome measure to detect change in beyond measurement error. For example, is the measure likely to show significant differences in the scores from admission to discharge after stroke? It is therefore important to use outcome measures that are sensitive to change across time, especially with regards to the level of severity of the patient's impairment, so as to avoid any ceiling or floor effects. For instance, if a large proportion of participants are already performing well on a measure at baseline, that is, their scores are close to the top of the scale, then the scale will not be able to capture much change in that group. One example is the Action Research Arm Test, which is a reliable and valid measure for accurately measuring moderate to high degrees of motor impairments. but it has shown to have poor sensitivity for measuring mild impairments. We should also consider whether the measures are sensitive to the degree of change expected from the intervention. Responsiveness is another important indicator of whether the measure is likely to capture real change. Responsiveness refers to the degree of change on a measure that represents meaningful difference that is often assessed against change in a measure of gold standard. I would like to move on to discussing what international experts are suggesting about the best measures. A few international initiatives have addressed this topic, such as the Core Outcome Measures in Effectiveness Trials Initiative, the National Institute of Neurological Disorders and Stroke, the International Consortium for Health Outcomes Measurement, and the group focusing on improving research outcome measurement in aphasia. The Stroke Recovery and Rehabilitation Roundtable, which is another international initiative, is coordinating a standardized approach to measurements in neurorehabilitation after stroke. And they have published 3 articles targeting standardized measurements in the International Journal of Stroke in 2017 and 2019. This group recommended the use of the Fugl-Meyer Motor Assessment part for assessment of body structure and function, and the Action Research Arm Test for activity limitation to evaluate sensory motor recovery of the upper limbs in stroke trials, amongst other recommendations. It is worth highlighting that even though the measurement protocol of the Action Research Arm Test is standardized, there is a lack of standardization regarding the weight, size, and source of testing materials. Cognitive losses are neglected areas of research in stroke rehabilitation. The Stroke Recovery and Rehabilitation Roundtable recommend the evaluation of cognition across different domains such as mood, apathy, anxiety, fatigue, and sleep. I will provide some resources about where to obtain more information about these standardized clinical measures later in this podcast. Next, we will discuss the role of technology in measuring outcomes. Technology-based assessment is providing us with an array of measures that can be used to evaluate performance to better understand the neurophysiological changes that occur when patients improve. These include kinematic measurements such as motion analyzers, kinetic assessments, as well as robotic assessments. These technologies offer objective and sensitive means to quantify movement, but their protocols are often not standardized, which makes it difficult to compare data across trials. For example, some labs may use 2D motion analyzers, whilst others may be using 3D motion analyzers using varied tasks. There has been some attempts to standardize robotic assessments. For example, the KINOM is a Canadian-developed robotic system which has been used in several stroke studies. The KINOM standard test uses standardized protocols to provide sensitive and objective measures of cognition, motor, and sensory function through the precise measurement of human behavior. In order to emphasize the importance of standardization of technology-based measures, the Stroke Recovery Roundtable recommended 5 performance assays of kinematic and kinetic assessments, including 2D planar reaching, finger individualization, grip strength, precision strength, and 1 functional task involving 3D drinking task. In general, there is a need for the development of assessments in stroke rehabilitation that are standardized and more reliable, valid, and sensitive than the current ones. The time taken to administer an outcome measure also requires careful consideration. The administration of these tests can vary from a few minutes to half an hour or longer. So in a busy clinical setting, your choice of outcome assessments is likely to depend on the amount of time you have to assess a patient. The box and block, for instance, is a quick and easy test to evaluate manual dexterity. It takes about 5 minutes to complete, and it can be useful for quick monitoring in clinical settings or for multi-time point assessments in trials. Alternatively, the Action Research Arm Test usually takes 10 to 20 minutes to administer, while the Wolf Motor Function Test can take up to 30 minutes to administer. The functional independence measure is often used in clinical setting and can take up to 40 minutes to administer. In rehabilitation trials, it is often recommended to limit assessments to 1.5 to 2 hours to minimize fatigue. So when is it a good time to assess? In any research study investigating effects of a rehabilitation intervention, outcome measures are used to assess changes before and after the intervention. It is also possible to administer assessments at different time points throughout the intervention for continuing monitoring. Although the same rationale should apply for conducting assessments in clinical settings, assessments are not always carried out at admission or at discharge for varied reasons. Consequently, it is not possible to objectively determine the extent of recovery on stroke survivors. The Stroke Recovery and Rehabilitation Roundtable recommend that for recovery trials, the first assessment should be completed within 7 days after stroke and follow-ups at 3 or 6 months post-intervention. At the Toronto Rehabilitation Institute, all patients are assessed at the beginning and then every 6 to 8 weeks. Clinicians are strongly encouraged to also assess at discharge. These assessment data are then used to inform clinical practice. It is crucial for assessors and therapists to be adequately trained to administer those measures to ensure reliability. There are multiple resources that can be accessed online. The Shirley Ryan Lab and the Stroke Engine websites provide in-depth description of the measures, at times accompanied with video instructions of how to administer a test. The evidence-based review of stroke rehabilitation is also accessible online and contains a chapter on outcome measures in stroke rehabilitation with summary reviews of 38 assessment tools used in the evaluation of body structure and function, activity, and participation. It is also valuable to refer to the clinical practice guidelines in stroke. The Canadian Stroke Best Practices provide recommendations for initial stroke rehabilitation assessment. To learn about stroke-specific assessments, the International Consortium for Health Outcomes Measurement website is a valuable resource about patient-centered outcome measures for stroke. They can also provide support in implementing these measures in your clinical setting. So how do you choose the most appropriate standardized outcome assessments and how to implement these measurements in a low-resource setting? You could start by referring to consensus-based recommendations from international groups such as the Stroke Recovery and Rehabilitation Roundtable. From these recommendations, identify a measure that is low-cost with robust psychometric properties. You can choose one measure to start with. Also, carefully consider what the hypothesized mechanism of change is and in what aspects of the person's life and domains these changes are most likely to be evident. That is, are they most likely to happen in the body structure and function, activity, or participation domains? Also, consider over what period of time the expected change will happen and how that change can be best identified. The choice of these measures should also be guided by the interest of researchers or clinicians. That is, their understanding of what he or she expects to change. It is also crucial that the researcher or clinician decides whether the contents of a particular outcome measure match the specific domains that the intervention will target. The cost and availability of the test are major considerations, especially in low-resource settings. Some assessments with strong psychometric properties such as kinematics and robotics are often costly and therefore unaffordable. Some alternatives could be clinical assessments that involve low-cost materials such as the Fugl-Meyer or the Action Research Arm test. So I hope that you have enjoyed listening to this podcast, which provides an overview of standardized assessment in stroke rehabilitation. The take-home messages of this podcast are: firstly, it is crucial to carry out outcome assessments to monitor patients' improvement during or after an intervention. Secondly, outcome measures are classified into 3 domains, which are body function and structure, activity and participation, according to the International Classification of Functioning Disability and Health Framework. Thirdly, choose outcome measures that are standardized and have robust psychometric properties. That is, they should be reliable, valid, with good sensitivity and responsiveness. Fourthly, it is useful to refer to international groups for their recommendations on outcome measures. Thank you.
Thank you for listening to this podcast. You can find additional stroke education material and resources in our World Stroke Academy website and social media channels.